Welcome to Joint Class. My name is Carrie. I'm one of the nurses that currently work at pre-admission testing here at Holy Family. I've been here for about 10 years. I've been a nurse for 27. We're going to go over some of the different things that you'll experience during your stay here for your joint replacement surgery. Again, thank you for choosing Holy Family. As you can see, you've received a folder that has multiple different handouts in it. We're going to go through those handouts in detail throughout the class. The handout, you can see that there's an orthopedic surgery handout. That kind of is the class in a nutshell in kind of portable form that goes through the different facets and different entities of the surgery itself. There's also a guide to pain management that discusses the different ways and the different mechanisms we use to treat your pain. There's also a handout in there that talks about anesthesia. Anesthesia, the two different types of anesthesia that we use are spinal and general. The anesthesiologist will have a discussion with you about this the day of surgery, but we just like you to have some education behind it so that you've heard of these two different forms previously so that you're not getting everything all at once the day of surgery. I just want to make a note here that even if you choose a spinal anesthetic, you will not be awake. You will still receive sedation on top of the spinal anesthetic. The surgeons usually like to do the spinals because it is obviously a lot less anesthesia because you have no pain response because it's eliminated that by doing the block. However, sometimes some people, because of their medical history or what have you, may not be able to have the spinal, in which case there's always the general anesthetic. There's also a handout there that says surgical guidelines for patients. This obviously is what we give to all of our patients having any type of surgery. That will be discussed in more detail. There's a little to-do list before your surgery. These are just some recommendations and some things that we recommend for you that you have in the house, have handy. We recommend that you program your surgeon's number into your cell phone. Just in case in the middle of the night, if something were to go awry or you have a question, it is automatically programmed in your phone so you don't have to fumble around looking for telephone numbers. There's also a handout regarding the Ensure drinks. These are the pre-surgical drinks we use. They are clear and they're used to optimize your nutrition and hydration going into surgery. There's also another handout that talks about nutrition and some foods that you should introduce or kind of consume more of going into surgery and after surgery, again, to help with healing, decreased bleeding, and things like that, preventing your potential for any type of complication or side effect. There's also the pre-admission screening for staff and MRSA. That will be discussed in more detail. In addition, that kind of coincides with that would be your pre-surgery HIPAA instructions. That's the soap that you receive. We're going to go over when to use that and how to use that. There's also a little evaluation regarding the joint class itself. We really recommend, we love your feedback. We like to know if we're doing things well, if we're doing things not so well. Please, it's anonymous. We want to know, we want to hear from you so that we can improve and strive to be better. The surgical stay is broken down into basically before surgery, day of surgery, and after surgery. As you all know, there's multiple different things that you've had to do to accomplish, even to get your surgical date booked. We're going to go to review these different types of things, the pre-op testing, your surveys, home environment, nutrition, the guidelines, all that happens before surgery. The day of surgery, we'll go through what to expect, the phases of your surgical stay, where you go, what you have done, what department, what area does what type of care. And then your discharge plan. Are you going home? Are you being admitted to the hospital? Sometimes, occasionally, people still go to a rehab setting, but usually that's discussed with your surgeon ahead of time and that plan is already in place before you arrive. Then after surgery, we're going to review some of the potential post-op complications. Know that these complications are just mentioned. We're striving to prevent these complications all throughout your stay, even starting before you arrive to us. Surveys before surgery. The Again, this is the before surgery. We kind of just went through the agenda. The surveys, pre-op testing, home environment, nutrition, and your guidelines are going to be discussed in the next slides. Surveys, your who's and who's, your promise, your goal sheet. These are all things that you're probably already familiar with that you've already completed for us. You will receive another survey, the exact surveys, in 6 months, and then again in a year. This is to evaluate and assess how we did, how you're doing, basically how you're doing. Did the surgery help? Did it not help? What worked for you? What did not work so well for you? How are you healing? How's your mobility? These are all things that we continue to assess and track to help us continue to strive for excellence and make sure that we're providing the very best care we can for all of our patients. The pre-op testing, this is that handout for the pre-admission screening for staff and MRSA. You will go down to the lab here and have a nasal swab done that will test for these 2 different types of staff. Basically, don't get nervous if you're positive for either one of them. It will not cancel your surgery. It will just change sometimes the antibiotics or the medications that we may give you before your surgery. If you are positive, that mupirocin 2% ointment will come into play. I will call you, say, hey, you know, Charlie, you tested positive on your screening. I just want to let you know that I called in the prescription to the mupirocin ointment to your pharmacy. They'll contact you when it's ready. You're going to use that in your nostrils twice a day for 7 days or up until your surgery date, whichever happens first. Sometimes when I call you, it's not actually 7 days to your surgery. It's maybe 4 or 5. You're just going to use that mupirocin until the day of surgery. You do not need to use that the day of surgery. In addition to the mupirocin, you can see down below, it's the HIBA-Cleanse instructions. You're going to do the HIBA-Cleanse and start the HIBA-Cleanse the same time you start the mupirocin. You're going to do this scrub for a little bit longer when you test positive. When you do the HIBA-Cleanse, after you shower, you're going to basically go in the shower, let that scrub wash all over your body, focusing on the extremity, leg, arm, whatever, with the scrub a little bit more intently. Do not overly scrub. You don't need to do that. You could just kind of use a loofah or face cloth or towel and just kind of wash that area a little bit better than you would let it wash over the rest of your body. Do not put it on your private areas or your sensitive areas, your face. Avoid those areas because it is kind of harsh and abrasive. Less is more, so to say. When you come out of the shower, do not put on any lotion, powder, anything like that. You're going to put on freshly clean clothes. We also recommend that your sheets and your bedding are also clean. We all slough off. Normally, we slough off our skin cells. The idea is that once you clean with the scrub, you don't reintroduce those skin cells. That's why we recommend that everything is clean that you put on. In addition to our screening, you're also going to have a pre-op appointment with your surgeon. This is where you're going to go over your medications, your medical history, potential, your medical clearance that you've probably already got. If you're on anticoagulation, these things should be addressed at your pre-op appointment. The surgeon should have already contacted your provider that provides your anticoagulation. If not, you need to reach out and let them know, hey, I'm scheduled to have my knee replaced. What's the plan with my Eliquis, my Coumadin? You know, we need to put a plan together when I can stop that and when it's okay to resume. Pain management. The surgeon will go over what your preference is for pain management. We do have an opioid-free option for patients. If they want to avoid opioids at all costs, we can make arrangements for that. He'll talk about what the plan is for your post-op pain management. Also, the GLP-1s, these are your Ozempics, your Wegovy's, those type of injectable medications, whether they're for diabetes or weight loss, they need to be stopped in advance also, at least a week prior to your surgery. Smoking. If you smoke, I'm sure the surgeon's already had a discussion with you about the fact that they don't want you to smoke any longer post-op or even pre-op going into surgery. It increases your risk to delay healing. It increases your risk of pneumonia and any type of lung complication you potentially can have. You really should have had a discussion to definitely decrease your smoking intake prior to surgery. That also coincides with any alcohol, recreational drug consumption. Alcohol use is okay in moderation, minimally to moderation. Anything excessive also needs to be addressed about how you can decrease it. Again, your complications are a little bit higher when you do smoke and use alcohol or recreational drugs consistently. Recreational drugs, we noticed that since the edibles have been legalized and a little bit more prominent, there is it does coincide with post-op pain control and the inability to kind of get your pain control get your pain controlled adequately post-op. The more edibles you consume prior to surgery, the more narcotics it takes for us to regulate and get your pain under control, which also will increase your complications for those type of side effects from the narcotics. A lot of times patients still have pain, but they're nauseous, they're vomiting. We've given them all this narcotic. It really hasn't changed their pain as much as it's really made them feel lousy overall. So we like to avoid that at all costs if we can to get your discharge in a timely fashion. Medical clearance. You've all been seen by your primary care providers because, again, like this is an elective procedure to some degree, we do require that you be seen by your doctor, your physician, whatever predisposing medical problems you have, whether it be diabetes, hypertension. We're not going to change those diagnosis or those medical problems, but we want to make sure that you're optimized and we're not going to make those things worse by doing this surgery. We don't want to put you at any more risk than we need to. Again, your primary care visit and then your pre-op lab and other testing. Your primary care physician is going to order some of the pre-op labs that the surgeon sent them that they want done before surgery. Whatever your primary care testing does not do, we will do here at the hospital. Don't worry, we're not going to duplicate any testing, but we do need to do, sometimes we need to do a blood test for a blood type so that we have your blood type on file in case by any chance you may need a blood transfusion. And like we discussed prior, you will also need to be screened for those two different types of staph. In addition to those two things, we may need to do an EKG or something else that is either too old from your primary care or that you've never been done at the surgeon or the anesthesiologist would like done prior to surgery. Again, based on your past medical conditions and your age sometimes. Home environment. This goes over setting up your home for safety, your physical safety. That includes getting rid of area rugs, making a well-lit pathway to the bathroom, night lights, small little LED things, something that you have a clear path from wherever you're going to be at night to the bathroom. We also recommend that you put everything you're going to need as far as, food, drink, necessities, cell phone, remote control, things like that they're all within reach and waist level. You don't want to be reaching up or reaching down after a joint replacement because it can throw off your balance and make you a higher risk for falls. Nobody wants to fall after having a joint replaced. It's never a good thing to fall in general, but especially after having a joint replaced, the last thing you want to do is complicate that any further. Meals. It may help to prep meals ahead of time so that all you have to do is kind of heat it up or just grab it out of the fridge or grab it off the counter to kind of snack on and eat and have handy. And caregivers. This kind of ties into the whole setting up your home and the meals component. We kind of recommend that someone's home with you for a couple of days after surgery, especially post-joint replacement, to make sure that you're kind of set, you're safe, you have a plan in place, and you can kind of navigate through your home in a safe fashion. Obviously, they have to go back to work. Again, we want them to provide you with a safe environment where everything is kind of waist level so that you can access it easily. You do need someone to drive you home the day of surgery and be with you the 24 hours after surgery because of the anesthesia requirements. Nutrition, what you should eat. You need to hydrate really well. There is a handout there from nutrition that discusses the foods that you should have consume more of before and after surgery. Hydration is always important. None of us are where we should be optimally for hydration status. But again, water, Gatorades, things like that will help. Going into that, also Ensure. We recommend that you have Ensures in the house. We'll go over the pre-surgical drink. Those are the 3 drinks that you have in front of you that you received from us. The handout that coincides with that is to have 2 drinks the day before. So basically you're going to have 1 drink, I recommend sometime late afternoon, early evening, and then another one before bed. And then the morning of your procedure, you're going to have another drink to be consumed about an hour before you're going to leave the house to come on the day of surgery. Now, ideally, this isn't an ideal world, but we understand that, you know, sometimes the day of surgery is difficult to kind of try to drink something, especially quick. If you cannot drink the whole thing the day of surgery, that's fine. Try to drink as much as you can before you leave the house. If this drink is the worst thing you've ever had your entire life, please do not force yourself to drink it. It doesn't benefit you in any way to force yourself. This drink, the pre-surgical drink, is high in electrolytes and proteins, carbohydrates, things to kind of optimize you nutritionally going into surgery, to lessen your side effects for anesthesia complications, and to obviously help you heal in a more time-efficient fashion. The Ensure post-meal supplements, we recommend that you have some of these in the home to go in case you're not hungry, you're not feeling hungry, which you may not because you're not going to be as active as you normally are. You want to stay nutritionally optimized as much as possible. So to drink a meal supplement is preferable to make sure you're getting your electrolytes, your protein, your carbohydrates, all things to help you to be at your maximum level to heal overall and help you feel better. The guidelines, as we've discussed before, there's that guidelines that we give to all our surgical patients. The 1 week before surgery, we kind of discussed this before at your primary care office, that things that need to be stopped and addressed. Ride home. The evening prior, we're going to call you to let you know exactly what time you're going to arrive and where. Do not shave. Please do not try to help us by shaving ahead of time the area that's going to be operated on. It will actually potentially cause a complication if you were to nick yourself or get a scrape, scratch, anything like that, any open area on the leg or arm that they're going to be operating on could potentially get your surgery canceled. Nothing to eat or drink after midnight. The exception to that is going to be the Ensure. You will not have anything to eat or drink after midnight, but that is not including the Ensure to drink the day of surgery. The medications that are listed there, those are the medications we want you to take with a sip of water the morning of your procedure. Even if you're on 10 other medications, that's okay. These are just the ones we want you to take the morning of your procedure. Make sure you bring a photo ID, your cell phone, and a cell phone charger. Your cell phone is going to be how you communicate with whoever your ride is that's going to be picking you up. Leave all your valuables at home besides your cell phone and your charger. However, there could be some delays and some wait time. So if you have an iPad, a Kindle, something like that, bring that with you so that you can occupy your time while you might be waiting. Wear some loose-fitting clothes, something that is elastic, that's kind of wide-legged because you're going to have a wide dressing on your knee, especially if you have having knee replacement surgery. Shoes, supportive shoes with a back. If they're slip-ons, that's okay. We just want them to have a back so your foot is not sliding in and out. If you have sleep apnea, bring your CPAP machine, hearing aids, glasses, any type of aids that you need or require to be able to optimize your hearing or seeing to be able to sign consents. We don't want you to have any makeup, lotion, deodorant, hair products, gel nails, nothing like that the day of surgery. Body piercings should be removed. Any type of jewelry in addition to that should be removed the day of surgery. We talked about some potential delays. Obviously, we're a hospital. We are 24/7. There are emergencies that can happen to delay potential surgeries. We try to keep the total joint replacements consistent and on time, but again, sometimes things happen that are out of our control. Bringing in some things to help, whether it's a Kindle, book, or crossword, whatever your choice is, will kind of just help occupy some of that delay and some of that time. Family members are welcome, but they're not going to be allowed in the patient care areas. So they would be able to wait in the family waiting room. There's a cafeteria, we have a coffee shop. Those type of things are fine. We recommend one family member, but no more than two. Also, if you become ill, if you have a fever, chills, develop any type of flu symptoms, please call your surgeon as soon as possible to get that addressed. A discussion needs to be had on potentially whether or not the surgery should continue based on how you feel. Next, we're going to go into the day surgery. This is surgical daycare. This is a little area where you're going to come in when you show up the day of surgery. You're going to come in through the main entrance here at Holy Family. You're going to take the elevator to the second floor. When you get off the elevator, you're going to take a right, and you'll see a little waiting area, and then you'll see girls behind the plexiglass. You're going to walk straight into where those girls are behind the plexiglass to check in for the day of surgery. Once you check in and sign all your, hospital consent and your insurance things, there will be a nurse or a tech that will come to get you from surgical daycare to bring you back to this area. This is where you're going to say goodbye to your family member, and they will take down the contact number for your family member and where they will call them to either pull up in the front or come up to the second floor to retrieve you when it's time for you to go home. This is also the phases of the surgical stay. Like we said, surgical daycare, then you'll go to the operating room, the post-anesthesia care unit, the discharge plan, home with services, or admission to the hospital as we discussed before. Okay, again, surgical daycare. This is where you're going to come. The tech is going to bring you back here. She's going to ask and confirm again once you are retrieved from your family member, confirm the surgery you're having done, what extremity, what your date of birth is, what your name is, all of those types of things to confirm that the procedure we're doing is correct, on the correct person, at the correct time. Informed consent. If you've already signed it with the surgeon in the office, you will be reviewing this with the surgeon at the bedside. He will go over the procedure again if you have any questions or concerns regarding the consent you signed with the surgical. You will also go over anesthesia consent. Anesthesia is the two different forms of anesthesia from that handout that was in your folder. Those are going to be discussed at the bedside. You and the anesthesiologist are going to come up with a plan. You're going to agree to the plan, and you'll sign consent based on that. He'll also probably introduce a CRNA that will be assisting him in the surgery. And then again, you'll sign consent. And they will also talk about a block. Anesthesia who will administer a nerve block in addition to the other anesthesia, whether it be spinal or general. Site marking. This is where the surgeon's going to mark the site. He's going to put his initials on either the correct arm or leg that's being operated on. This is again confirming that we're doing the right thing at the right time on the right person. The nurse is going to review your medication list, confirmation of the last food or drink, confirmation of the last time you took your medications, the plan of care here. You're going to be given multimodal approach, we call it. So there's multiple different agents we're going to use to help your pain control post-op. Anesthesia is going to talk about the block, which is basically to numb whichever arm or leg is being operated on for the length of the surgery, and then a little bit longer. Ideally, some of them can last up to 12 to 16 hours. In addition to that pre-op, the nurse is going to administer what the surgeon orders. The surgeon usually will order an anti-inflammatory, Tylenol, and some type of nerve agent sometimes, whether it be a gabapentin or a Lyrica or something like that. You will also be giving something called TXA, which is transaschemic acid. This is a protein that's used that helps with clotting and decreasing of bleeding during surgery. This sometimes is given by mouth, but a lot of times is given in the IV and you don't even know that you're getting it. We just like to mention it because it is something that we use to intervene to try to prevent your potential for a post-op transfusion. And also that it could be given by mouth, and it can be in that little cocktail that you're giving before you even go into surgery. After you've had all of these things completed in surgical daycare, you've had your IV put in, your vital signs done, you've emptied your bladder, they've scrubbed you with the HibaCleanse scrub once again completely, the handoff will be given to the operating room nurse, who you probably have met during some time in your surgical daycare stay. You will be then, once all the consents are signed and things are all in place and all the boxes are checked off, a lot of times the anesthesia will give you some type of sedation as you're on your way into the operating room. So sometimes you may or may not remember going into the operating room at all. We will kind of go over what to expect in the operating room because the idea is that they do wake you up in the operating room. So we're going to kind of go over what to expect when you do wake up or when you do go into the operating room awake. Sometimes the sedation, because you're going to transfer from the stretcher into that you're on onto the operating room table. Pain management, again, we've discussed that. Between the block, the Tylenol, the anti-inflammatory, you're also going to have some type of ice mechanism, whether it be a cryo cuff or ice pack, to help with your pain control post-op. Pain management. This is our pain scale that I'm sure you're familiar with. Obviously, 0 is not realistic post-op for pain because we did make an incision, so all incisions hurt. But obviously, we don't want you to be at a 10. We like you to kind of be anywhere from like a 4 or 5 or below. We'll be reassessing and assessing your pain level. Please communicate with us where you're at so we can determine what you may need or what you're due for as far as your pain control. Our other different types of pain medication, like I discussed prior, this is the Tylenol, the nerve block, the narcotic, which is kind of a last resort for us. You'll be discharged on Tylenol around the clock, anti-inflammatory around the clock, potentially a nerve agent around the clock, in addition to ice and elevation and mobility and doing your exercises. Because believe it or not, sometimes just moving your joints after a replacement kind of helps with the pain. A lot of pain is because those muscles around it spasm and get tight, which causes it to be stiff. If all of those interventions are not working and your pain is starting to tick up to like a 4 or a 5, then that's when you would want you to introduce the narcotic or the prescription medication that the surgeon has prescribed. As you know, there are all kinds of side effects to some type of narcotics, constipation being the primary, kind of flowing with nausea. So obviously the less we use these, the less you're going to have these types of side effects. Usually the surgeons will tell you to use some type of stool softener or laxative in your post-op course to counteract some of the constipation and bloating, gas feelings after surgery. Multimodal, again, goes into what we just discussed as far as these different types of medications and nerve blocks. The operating room. This is what the operating room looks like. You'll be asked, that's the table that you'll be asked, sometimes be asked to transfer to. If not, they'll do it, the staff will do it themselves. The anesthesia will be at your head, the head of your bed, controlling, obviously your airway and giving your medication, putting you to sleep and waking you up. In addition to the anesthesiologist, the operating room nurse, and your surgeon, there could be potentially another 8 or 10 people in this room at any given time. We say that because we don't want you to be concerned if you do wake up or if you do go in this room and all of a sudden there's a bunch of people standing around. It does not mean anything's wrong. This is a normal functioning day in the operating room here. They all have their own little jobs and their own little specific tasks that they are responsible for. There are techs that are responsible for the surgical equipment. There are techs that are responsible for the anesthesia equipment. There are representatives that are here to represent their different types of equipment. So there's always someone there. Each entity has its own little personal attendant for it, let's just say, who's in the room and the plan of care. The plan of care in the operating room obviously is to put you to sleep, do the surgery, and wake you up in the safest mechanism and manner possible. The surgeon will also have physician's assistants or nurse practitioners that will be assisting him with the surgery. Once the surgery is complete, they usually close these type of surgeries, surgical incisions with some type of glue, whether it be Dermabond or Prineo. Those are kind of the brand names of what we use. And then there'll be an Aquacel dressing that will be placed over that. This Aquacel dressing is particular because it has some antimicrobial properties in it, so it does kind of decrease in the risk of bacteria forming. Ideally, this is the most ideal setting to have any type of procedure. It's a sterile environment. So that dressing that's going on is getting put on in a sterile environment, which is optimal to decrease your infection. Usually those stay on for an extended period of time because of the idea that this is put in a sterile environment. The longer they can maintain that sterile environment, the better it is to decrease your potential for infection post-op. Once the surgeon is done with his part, then the anesthesia CRNA or the doctor will wake you up, ask you to take a deep breath. Potentially you may have a mask on your face when you wake up. Do not feel anxious. This is normal. A lot of times people get really anxious when things are on their face or they feel like they're suffocating or kind of claustrophobic. That's why we like to mention these things to you so that you're aware. So you're like, okay, yeah, I'm waking up. Oh yeah, that's right. What's on my face? That's right, it's an oxygen mask on my face. They told me that was going to be there. Anesthesia is going to make sure you can follow some commands before they transition you into the post-anesthesia care unit, which is where we're going to next. You can see this little guy. I'll explain the machine that he's using in a few moments. Plan of care in the PACU. This is where the bedside handoff is going to happen. The operating nurse is going to tell the nurse in the recovery room, hey, this is the hospital course. He got these drugs at this time, and do a handoff to them. You'll be placed on multiple different monitors, a heart monitor, oxygen monitor. You'll have supplemental oxygen applied, whether it be in your nose or on your face. The recovery room nurse is also going to be assessing your incision. Is there drainage? Where is the drainage? Sometimes they'll take a pen and kind of mark around where the drainage is to make sure when they reassess, they can see, okay, yeah, it was inside that line, but now it's going outside the line. All these interventions to kind of assess you frequently to make sure you have the most optimal and the best outcome. They're also going to go over your functional assessment. This has to do with those exercises that physical therapy is going to talk about. They're going to have you doing these pretty quick after surgery to see, do you have sensation? Can you move? How much can you move? How much can you feel? This is all to determine where the block is, where you are at the stage of the block. Are you getting ready? Is it wearing off? Is it still in full effect? All kind of assessing and reassessing when they think you're going to be able to bear weight, to stand up, to follow commands, to be able to participate in movement. Sleep apnea. This incentive spirometer that this is in the picture here, this is definitely going to be introduced if you have any type of sleep apnea. It will also be introduced even in patients that do not have sleep apnea. This is basically as you're doing exercises for every other part of your body, these are exercises that are specific to your lungs. When you have anesthesia and narcotics, it suppresses your respiratory drive. We know this. We know these are side effects of these type of medications. So we want to get your lungs operating and functioning to full capacity as quick as possible. This is going to have your lungs expanding to their optimal level immediately post-op to decrease your chances of getting any type of post-op pneumonia or lung issue. The idea is that that mouthpiece that he has in his mouth, you're going to inhale. The blue ball that's there is going to measure your inhalation, which is your breath in. You're going to take a deep breath in, hold it for usually the count of 3 seconds, and then blow it out. This is exercising your expansion, your lung expansion, as we said, to kind of keep everything open to the maximum capacity as possible. I usually tell patients not to focus too much on where the ball, what number the ball is at, more just to make sure you're doing the exercises to the maximum capacity that you can at the time that you're doing it. Obviously, immediately post-op, the ball's not going to go that far because you're still usually pretty anesthetized, we call it, which means that you're under a heavy amount of anesthesia still. As you wake up and as time goes by, that ball should go all the way to the top or pretty close to it, which just shows that's how you can tell that your lung expansion is improving and getting to be to its normal capacity. Pain and pain control goals, the nurse also is going to assess, hey, what number is your pain? Where do you think your pain is at? This is where they'll discuss what the plan is going to be and for your pain control, where you're at with your non-narcotic medications, applying the ice pack, using some mobility, determining what ideally is where you want to be for a pain number. What is not acceptable? What you can't you can't tolerate, what type of pain? Because everyone's pain and everyone's interpretation of what their pain is very patient specific and very different depending on the patient, your prior experience with pain, your prior experience with pain medications. There's a lot of other social and things that come into play when it comes to pain and pain control. Again, be given this, hey, you'll be given a number. These smiley faces are just in case someone can't talk, or if you're a child, they can point to certain things, or you can kind of look at the face. If a patient's telling me their pain is a 2, but yet their face looks like it's an 8, we'll have a conversation of kind of where to meet in the middle. And it's okay to have pain. We just don't want you to get too far or too close to a 10. What happens with post-op pain is once your pain gets high or to a high level, it's very difficult to bring it back down to a tolerable level. It kind of, that's why we make sure that we have the anti-inflammatories, the Tylenols, those type of things around the clock with your cryo cuff and your ice packs, because we want to make sure that we're not letting things get to a point where it's too far ahead, and we kind of hit a point of no return sometimes. So ideally, pain control for a reasonable level. This also coincides with your discharge plan. Depending on how you're doing in PACU will depend on what your discharge plan is going to be. There are some people that even with a little bit of anesthetic, they just can't they're really too sleepy, or they're nauseous, or they're really too dizzy that we can't sit them up or get them to participate in physical therapy. These are all things that are completely fine. It just will change your discharge plan as opposed to going home same day to potentially requiring an admission. If you are to go home same day, you're going to be it's either going to be home with services or admission, hospital admission. For discharge home, you're going to be going back to surgical daycare where you started your day. That's where you'll go over, and they'll go over your mobility status. Can you feel things? How are you doing? Are you still numb? Can you bear weight on your feet? Can you feel your feet? Are you going to be able to walk with physical therapy? Are you going to be able to walk to the bathroom? These are all things that need to be in place in order to get you to work with physical therapy to be able to go same day. What flows into this also is going to be your pain status. Are you at an acceptable pain level to be able to participate with physical therapy? Your cryo cuff. So if you're having a shoulder or a knee, you'll receive this cryo cuff box, or machine we call it. Basically, our recommendation is that you buy 8-ounce frozen water, you buy 8-ounce water bottles. These are going to be put into the freezer where they can be frozen, to be able to recycle those, as opposed to buying multiple bags of ice, trying to fill things with ice, trying to operate a cryo cuff with a walker with things that when you've had surgery, after you've had surgery. 4 frozen water bottles will fit in the bottom of that cryo cuff. So once you put the water bottles in, you will fill to the water line, and then you'll put the lid on, plug it in, and you should be good for a couple of days. The idea is that those water bottles that are frozen last longer than the ice, also keeping it colder longer. When you do have the cryo cuff on, please make sure you have a barrier between the cryo cuff pad and your body. It is very cold, and people can get frostbite from it, believe it or not, because you still, remember, they did all those numbing agents in there. So your leg is still pretty numb from that. So because you have decreased sensation, you're not going to be able to feel exactly how cold it is. So always make sure you have a hand towel or cloth in between your skin and the cryo cuff itself. And a physical therapy clearance. This is kind of what we discussed. Like we said, you need to be able to have your pain controlled, be able to ambulate, not be nauseous, things like that, to be able to work with physical therapy on the stairs. Talk about ambulating through the department, be able to eat, drink, in addition to a multitude of other things, to be able to go home same day. Going home same day, you'll go home with visiting nurses. The nurse on surgical daycare will communicate with the visiting nurse. She'll let them know, hey, yeah, Charlie's all set, he's teed up, he's scheduled to go home today. For them to be able to make a visit for the next day. To get you home safe, we need to make sure that that VNA care system can come in the next day to evaluate and start working with you. If for some chance they cannot, then we need to rediscuss your discharge plan. More than likely, you'll end up having to be admitted to the floor overnight. The nurse in the surgical daycare area also communicates with the visiting nurses initially when you're transferred, to let them know that you are still on course for your discharge home same day. Now, again, I always like to tell patients not to be discouraged if by some chance they end up having to be admitted, because everything has to fall into a certain time frame. Depending on how long physical therapy is going to be there, depending on how you're doing, a lot of these things are out of your control, and you really can't do anything about them. Whether you're nauseous or you're vomiting, or you can't urinate on cue for when you need to. It happens. It's normal. In which case we would just have you admitted overnight. When you do get discharged, whether it be from us or from the floors, you're going to have a packet of information. In this packet will be your visiting nurse agency. The plan is that they come in for the first, up until you're scheduled for your follow-up appointment with your surgeon. They will be the ones to do the first dressing change. As I said before, that first dressing potentially can stay on for up to 2 weeks. They're going to be the ones to tell you what exercises to do, when to do them, how to do them. They will go over those things in detail. You will also have your prescriptions, where your prescriptions were sent to, what your prescriptions are, when you're due for them again, when you're due for your pain medications, when you're due to take your regular schedule of medications, and your follow-up appointment with your surgeon. That will also be given to them, given to you on your discharge paperwork. Again, like we said, if all of these things fall into place and the stars are aligned, you will go home same day. If by some chance, again, you are not able to do those things, you'll be admitted to the floor. This is a picture of St. Mary's. This is where we send you. More than likely, it will just be overnight. Again, the discharge plan is the same. Mobility status, pain assessment. We mentioned the cryocuff again, physical therapy clearance, nurse and visiting nurse. Everything that happens in surgical day just transfers over to St. Mary's on the floor. You'll also you potentially may be seen by a case manager. They will be the ones to communicate more than likely with the visiting nurse when your discharge is going to be, again, to make sure they can come in same day. You might see a case manager, you may not. The physical therapist or nurse may be the ones to communicate with them. Again, the cryocuff with the 8 frozen water bottles, just to kind of make things easier when you go home. You will be, again, the last time you took your medications, when you're due for pain medicine, all of these things transfer over to St. Mary's so that when you are on the floor, you'll get your regular scheduled medications, and they will continue with your pain control and the pain plan as it was discussed in the other previous departments. Now, after surgery, like we discussed before, discharge paper and instructions about. After surgery, these are the potential post-op surgical complications that can happen actually with any surgery that you have. Infection being the number one. We've made an incision introducing your bacteria. Again, the surgical environment, the amount of times that you use the HIPAA cleanse, the surgeon scrubbing, the scrubbing the day of surgery in the surgical day area in addition to the surgeon scrubbing, the antimicrobial dressing we put on, the one-time dose of antibiotics you get. All of these things are integrated and in place to prevent the potential for this. For DVT or blood clot, mobility is the key to that. That's why we get you up same day, ambulating, working with physical therapy, trying to get you as mobile as we can that first day. You also probably noticed that you had those Betadine sleeves that were in place, those massagers. Those also help when you're in bed with preventing blood clots. The exercises that physical therapy gave you to do in bed, those all things helping to prevent you from developing a blood clot. In addition to all of those mechanisms, the surgeon will also usually discharge you home with aspirin. You'll be discharged on a baby aspirin. That will also help with your prevention of blood clotting. Pain. Of course, we've discussed pain in 7 at least different entities of this. We want to make sure that you're adequate and you're reasonable pain level so that you can participate, you can walk, you can do all the things you need to do to prevent the other complications. Pneumonia is the final one. That is the one, like we discussed, if you smoke or do any type of vaping, things like that, or if you have COPD, asthma, any type of lung condition, you're going to be a little predisposed to these type of things. This is why we implement the incentive spirometer, the mobility and the movement, all things to decrease and to prevent any type of complication having to do with your lungs. All of these entities come into play, and we provide the best care we possibly can in any given moment in all of our facilities to prevent you from having any type of complication, to make your overall stay a very good and positive stay so that does not make you anxious if you were ever to need something again. Next slide here. I want to thank you so much for attending class and choosing Holy Family to have your total joint replacement surgery. If you ever have any questions, please don't hesitate to reach out. Your surgeon is a great resource. There's always someone on call 24/7. You also will have visiting nurses where you'll have their contact information. Feel free to reach out to them with any questions related to your surgery. There's also a card that's in that folder that you got with my contact information and pre-admission contact number. Before surgery, or after you watch this class, if you can think of things that you have a question about, please feel free to reach out and call us. We are always here to help. Please feel free to leave a message and we will gladly call you back within 48 hours. I want you to have a wonderful day, and I hope you had a great experience here at Holy Family.